The TORCHES acronym organizes the major congenital infections: toxoplasmosis, others including syphilis, varicella-zoster virus and parvovirus, rubella cytomegalovirus, and herpes simplex virus. These represent the classic pathogens that can cross the placental barrier and infect the developing fetus. Timing of maternal infection fundamentally determines the severity of fetal consequences. Earlier gestational exposure typically results in more devastating effects than infections acquired later in pregnancy. This timing principle explains why first trimester rubella causes profound malformations, while late pregnancy infection might be asymptomatic. The clinical challenge lies in recognizing that many congenitally infected newborns appear completely normal at birth. Despite this asymptomatic presentation, these infants remain at significant risk for developing long-term sequelae, including sensory neural hearing loss, visual impairment, and developmental delays that may not manifest until months or years later. The timing of maternal infection creates predictable patterns of fetal involvement. First trimester infections cause malformations as organs are developing. Second trimester infections primarily damage the central nervous system during critical periods of brain development. Third trimester infections present as active disease since the fetus has developed immune responses, but pathogens can still cause acute illness. Transmission rates aren't uniform and depend on 4 critical variables. Pathogen virulence determines how easily organisms cross the placental barrier. Maternal immunity from previous exposure or vaccination can provide protection. Placental integrity affects the barrier function between maternal and fetal circulation. Gestational age influences both placental permeability and fetal susceptibility. 2 findings appear universally across congenital infections, regardless of the specific pathogen: intrauterine growth restriction and hepatosplenomegaly. These consistent manifestations provide important clinical clues when evaluating newborns for possible congenital infection. Cytomegalovirus stands as the most common congenital infection worldwide, affecting 1 to 2% of all live births. These numbers represent thousands of affected newborns annually, making CMV a significant public health concern that every neonatal practitioner encounters regularly. The transmission patterns reveal why CMV creates such clinical challenges. During primary maternal infection, when mothers have no existing immunity, transmission rates reach 30 to 40%. However, when CMV reactivates in mothers with existing immunity, transmission drops dramatically to just 1 to 2%. This difference explains why first pregnancies or mothers from low CMV prevalence areas face higher risks. Here's the critical clinical insight: 90% of infected newborns appear completely normal at birth. Yet among these asymptomatic infants, 10 to 15% will develop significant sequelae later. This makes CMV the leading non-genetic cause of sensorineural hearing loss, often presenting months after birth when initial hearing screens were normal. The 10% of infants with symptomatic CMV disease present with a constellation of findings that reflect multi-organ involvement. Growth restriction and microcephaly indicate early fetal infection affecting overall development and brain growth. The neurologic manifestations include periventricular calcifications, which appear as bright spots on head imaging, and ventriculomegaly, indicating brain tissue loss or cerebrospinal fluid accumulation. The classic ocular finding, chorioretinitis, appears as inflammation of the retina and choroid that can severely impact vision. Hepatosplenomegaly reflects hepatic involvement, often accompanied by direct hyperbilirubinemia that creates a cholestatic picture rather than simple physiologic jaundice. Hematologic involvement typically presents as thrombocytopenia, which can manifest as petechiae or bleeding tendency. The characteristic blueberry muffin rash represents dermal extramedullary hematopoiesis, creating purple-blue papules that indicate severe fetal infection. When you see this combination of findings, particularly growth restriction with hepatosplenomegaly and neurologic involvement, CMV should be your leading diagnostic consideration. Timing is absolutely critical for CMV diagnosis. You must test within 21 days of birth to confirm congenital infection. After this window closes, you cannot distinguish between congenital infection and postnatal acquisition, making early testing essential for proper diagnosis and management decisions. The preferred diagnostic approach uses PCR testing of urine or saliva, both offering excellent sensitivity and specificity above 95%. These molecular tests provide rapid, reliable results that guide immediate treatment decisions. Urine collection requires catheterization or bag collection, while saliva can be obtained non-invasively, making it particularly useful in stable infants. Viral culture remains an option, but requires 2 to 6 weeks for results, creating delays that can impact treatment timing. Serology proves unhelpful in newborns because IgM testing shows only 70% sensitivity, missing many infected infants. IgG antibodies simply reflect transplacentally acquired maternal antibodies rather than infant infection status. After 3 weeks of age, positive tests cannot distinguish congenital from postnatal acquisition, emphasizing the importance of early testing. Treatment decisions focus on symptomatic infants who benefit from antiviral therapy. Valganciclovir at 16 mg per kilogram twice daily for 6 months represents the standard treatment regimen. Starting treatment within the first month of life maximizes effectiveness, so early diagnosis becomes crucial for optimal outcomes. The medication requires careful monitoring because neutropenia and liver function abnormalities can develop during treatment. Regular complete blood counts and liver function tests help detect these complications early. Despite these monitoring requirements, treatment provides significant benefits by improving hearing outcomes and decreasing the severity of developmental delays. Management of asymptomatic infants remains controversial because the benefits of treatment haven't been clearly established in this population. However, all infected infants, whether symptomatic or asymptomatic, require comprehensive follow-up care. Serial audiology testing becomes crucial because hearing loss can develop or progress after birth. Ophthalmology evaluation helps identify and monitor retinal involvement that may affect vision development. Long-term management centers on detecting and addressing the progressive nature of CMV complications. Hearing assessment requires particular attention because initial newborn hearing screens may be normal even in infected infants. Progressive sensory neural hearing loss commonly develops, making serial testing every 6 months until age 6 years essential for early detection and intervention. Developmental assessment helps identify cognitive delays or motor impairments that may emerge as children reach developmental milestones. Vision screening complements ophthalmology evaluation to monitor for progressive retinal damage that can affect visual development and learning. Head imaging becomes important in symptomatic infants to monitor for progressive brain changes, hydrocephalus, or other complications requiring intervention. Family counseling addresses 2 critical areas: helping families understand the implications for future pregnancies, since CMV can recur or reactivate, and teaching hygiene measures to prevent transmission to pregnant contacts. These hygiene practices include careful hand washing after diaper changes and avoiding sharing utensils or drinks, particularly important given that infected infants can shed virus for months. Toxoplasmosis demonstrates a unique epidemiologic pattern that requires maternal primary infection for transmission to occur. This means mothers who have never been exposed to Toxoplasma before pregnancy face the risk, while those with existing immunity from previous exposure rarely transmit infection to their fetus. Cat feces represent the classic exposure source, though undercooked meat and contaminated soil also pose risks. The transmission pattern creates an interesting paradox. As gestational age advances, transmission rates actually increase dramatically. First trimester shows 10 to 15% transmission, second trimester reaches 25%, while third trimester transmission soars to 60 to 90%. However, severity follows the opposite pattern. It's inversely related to gestational age at maternal infection. This inverse relationship means first trimester infections, though less likely to transmit, cause severe fetal damage when transmission occurs. Third trimester infections transmit much more readily, but typically result in mild disease or asymptomatic infection. In the United States, congenital toxoplasmosis affects 1 to 10 per 10,000 births, making it relatively uncommon but clinically significant when it occurs. The classic triad of toxoplasmosis consists of hydrocephalus, intracranial calcifications, and chorioretinitis, though having all 3 findings simultaneously is actually quite rare. This triad reflects the organism's predilection for the central nervous system and eyes. The intracranial calcifications in toxoplasmosis appear diffuse throughout the brain, contrasting with the periventricular pattern seen in CMV infection. Beyond the classic triad, affected infants may present with microcephaly when brain damage is severe, seizures reflecting neurologic involvement, and the typical findings of congenital infection, including hepatosplenomegaly. Some infants develop jaundice or various rashes as part of their systemic illness. The clinical challenge mirrors other congenital infections. 70 to 90% of infected newborns appear completely asymptomatic at birth. This high rate of asymptomatic presentation means you cannot rely on clinical appearance alone to rule out infection. Even asymptomatic infants remain at risk for developing chorioretinitis or other complications months to years later, particularly affecting vision and cognitive development. Diagnostic approach begins with maternal screening to identify mothers at risk, particularly those with primary infection during pregnancy. This screening helps guide the need for fetal monitoring and neonatal testing after delivery. Neonatal testing employs multiple strategies because no single test provides complete diagnostic certainty. Toxoplasma-specific IgM and IgA antibodies can indicate neonatal infection since these antibodies don't cross the placenta like IgG does. PCR testing of blood, cerebrospinal fluid, or urine can detect toxoplasma DNA directly. Placental examination may reveal characteristic histologic changes or organisms. Serial IgG testing provides particularly valuable information by comparing neonatal titers to maternal levels over time. Rising IgG titers in the infant indicate active infection rather than just passively transferred maternal antibodies, which should decline over the first months of life. Every suspected case requires ophthalmology examination to detect chorioretinitis, which may be the only manifestation of infection. Head imaging with CT or MRI reveals the characteristic pattern of intracranial calcifications and can detect hydrocephalus or other structural abnormalities. Treatment requires a 3-drug combination that works synergistically against toxoplasma. Pyrimethamine serves as the primary anti-toxoplasma agent, started with a loading dose followed by daily maintenance dosing. Sulfadiazine provides additional antiparasitic activity and works together with pyrimethamine to inhibit folate metabolism in the organism. Folinic acid, specifically not folic acid, prevents the bone marrow toxicity that can result from folate pathway inhibition. This distinction matters because folinic acid bypasses the metabolic block created by the anti-toxoplasma drugs, while folic acid would interfere with their effectiveness. Treatment duration extends for a minimum of 12 months because toxoplasma can establish persistent infection requiring prolonged therapy. Monitoring focuses on potential drug toxicity, particularly neutropenia from pyrimethamine and sulfadiazine, requiring regular complete blood counts. Liver function tests help detect hepatotoxicity. Repeat ophthalmology examinations track the response of chorioretinitis to treatment. When active chorioretinitis threatens vision, steroids may be added to reduce inflammation, though this requires careful consideration given the risk of immunosuppression. Seizure management becomes necessary when neurologic involvement causes epilepsy, requiring standard anticonvulsant therapy alongside anti-toxoplasma treatment. Congenital Rubella Syndrome demonstrates one of the most dramatic examples of how timing determines teratogenic outcomes. While maternal vaccination has made this syndrome rare, understanding the gestational age risks reveals fundamental principles of embryology and organogenesis that apply across many congenital infections. The statistics tell a compelling story about critical developmental windows. Before 12 weeks gestation, when major organ systems are actively forming, 85% of fetuses exposed to rubella will develop abnormalities. This coincides with cardiac development at 4 to 8 weeks, eye formation at 4 to 7 weeks, and inner ear development at 7 to 11 weeks. Between 13 and 16 weeks, the risk drops to 50% as some systems complete their most vulnerable phases, while by 20 weeks, defects become rare because organogenesis is essentially complete. The classic triad reflects this developmental timing. Pearl-like cataracts appear white and opaque rather than the clear lens of normal eyes, often visible to the naked eye as white pupils. The cardiac defects, patent ductus arteriosus and peripheral pulmonic stenosis occur because rubella disrupts normal vascular development during the critical first trimester. Cochlear deafness results from inner ear damage during the precise weeks when hearing structures form. The infectious nature creates immediate clinical urgency. These infants shed massive amounts of virus through respiratory secretions and urine for months, making them walking sources of infection. Any pregnant contact without immunity faces the same devastating risks, making isolation not just recommended, but absolutely critical. The clinical manifestations of congenital Rubella syndrome reflect the virus's ability to disrupt multiple developing organ systems simultaneously, creating a constellation of findings that often appear together because they share common developmental timeframes. The ocular abnormalities extend far beyond simple cataracts. Microphthalmos means the eye itself is smaller than normal because viral infection arrested eye growth during critical developmental phases. The pigmentary retinopathy creates the pathognomonic salt and pepper appearance because rubella damages retinal pigment epithelium, causing clumping and migration of pigment that creates the distinctive speckled pattern on fundoscopic examination. This pattern is so characteristic that experienced ophthalmologists can diagnose congenital Rubella syndrome from the retinal appearance alone. Glaucoma develops secondarily when abnormal eye development creates poor drainage of aqueous humor, leading to increased intraocular pressure. Patent ductus arteriosus becomes the most common cardiac defect because the ductus arteriosus normally closes shortly after birth through a complex process involving prostaglandins and muscular contraction. Rubella infection disrupts this process, leaving the connection between aorta and pulmonary artery permanently open. Peripheral pulmonic stenosis affects the branch pulmonary arteries rather than the main valve, creating multiple areas of narrowing that obstruct blood flow to the lungs. The blueberry muffin rash provides a visible marker of how profoundly rubella disrupts normal blood cell development. When bone marrow function becomes impaired, the body compensates by producing blood cells in the skin, liver, and spleen, a process called extramedullary hematopoiesis. These purple papules represent actual blood cell production occurring in the dermis, making the skin literally a blood-forming organ. Diagnosing congenital Rubella syndrome requires understanding how the immune system responds differently in infected fetuses compared to postnatal infections, leading to unique diagnostic patterns that persist long after birth. Rubella-specific IgM antibodies provide the most direct evidence of active infection because IgM cannot cross the placenta, meaning any detectable IgM in the newborn represents the infant's own immune response to infection. The persistence of IgG antibodies beyond 6 months becomes diagnostically crucial because it distinguishes between two very different scenarios. Maternal antibodies transferred across the placenta follow predictable decay kinetics, typically becoming undetectable by 6 to 12 months. However, when the infant produces antibodies from actual infection, these IgG levels remain elevated or even increase over time, providing clear evidence of congenital infection rather than passive maternal protection. Viral culture from pharyngeal secretions or urine directly demonstrates ongoing viral replication and shedding, though results require several weeks. PCR testing revolutionizes diagnosis by detecting viral nucleic acids within hours rather than weeks, allowing rapid confirmation that guides immediate isolation decisions and family counseling. The absence of specific antiviral therapy means management focuses entirely on minimizing complications and optimizing developmental outcomes. Cardiac defects like patent ductus arteriosus may require surgical ligation if they cause congestive heart failure or pulmonary hypertension. Cataracts demand urgent ophthalmologic intervention because visual deprivation during critical periods of brain development can cause irreversible cortical blindness, even if the cataracts are later removed successfully. The 1-year isolation requirement reflects the prolonged viral shedding that makes these infants ongoing sources of transmission. Unlike many viral infections where shedding stops within days or weeks, rubella-infected infants can shed virus for 12 months or longer, creating persistent risk for pregnant contacts throughout this extended period. Neonatal herpes simplex virus infection demonstrates a completely different epidemiologic pattern from the other congenital infections we've discussed. While HSV2 causes 85% of cases and HSV1 accounts for 15%, the critical distinction lies in when transmission occurs rather than which virus type is involved. The transmission timing statistics reveal why neonatal HSV creates such different clinical challenges. Only 5% of infections occur in utero, making true congenital HSV quite rare. The vast majority, 85%, happen during the peripartum period as the infant passes through an infected birth canal or encounters infected maternal secretions during delivery. Another 10% occur postnatally through contact with infected caregivers or family members. Understanding the risk factors helps predict which infants face the highest danger. Primary maternal infection poses the greatest threat because mothers lack protective antibodies, have higher viral loads, and shed virus more extensively. When this combines with prolonged rupture of membranes, the exposure time increases dramatically. Fetal scalp electrodes create direct portals of entry through the skin barrier, transforming what might have been superficial exposure into direct inoculation. The disease manifests in 3 distinct categories that reflect different patterns of viral dissemination and organ involvement, each carrying vastly different prognoses and treatment implications. The 3 categories of neonatal HSV disease represent a spectrum of viral dissemination that determines both prognosis and treatment intensity. Understanding these categories helps predict outcomes and guides clinical decision-making about treatment duration and monitoring intensity. SEM disease, affecting skin, eyes, and mouth, represents 45% of cases and offers the best prognosis when recognized and treated promptly. The classic vesicular lesions provide visible clues to diagnosis, but here's the crucial clinical pearl. 40% of infants with SEM disease never develop the characteristic vesicles. This means you cannot rely on the absence of skin lesions to rule out HSV infection, particularly in a clinical context suggesting viral illness. CNS disease accounts for 30% of cases and carries significant morbidity even with appropriate treatment. The virus shows particular tropism for temporal lobe structures, causing encephalitis that manifests as seizures, lethargy, and altered mental status. The cerebrospinal fluid typically shows pleocytosis with elevated white blood cells. Though early in the disease course, CSF findings may appear deceptively normal. Disseminated disease represents 25% of cases but carries the highest mortality because multiple organ systems fail simultaneously. The liver, lungs, adrenals, and central nervous system all become involved, creating a picture that can easily be mistaken for bacterial sepsis or other causes of multi-organ dysfunction in newborns. The timing of symptom onset provides important diagnostic clues, with most cases presenting between day 5 and 21 of life. This window reflects the incubation period following peripartum exposure, though symptoms can appear earlier with heavy inoculation or later with lighter exposure. True congenital HSV infection, acquired in utero, creates a devastating pattern of structural abnormalities that reflects viral damage during organogenesis. Microcephaly and hydranencephaly indicate severe brain destruction, while cicatricial skin lesions appear as healed scars that mark sites of intrauterine viral replication. Limb abnormalities can include actual loss of digits or limbs, representing the most severe form of intrauterine viral damage. Peripartum infection, the most common form, often mimics bacterial sepsis with fever, lethargy, poor feeding, and respiratory distress. This clinical similarity creates diagnostic challenges because the initial presentation may be indistinguishable from Group B, streptococcal sepsis, or other bacterial infections. The key insight is that vesicles appear in only 60% of cases, meaning nearly half of infected infants lack the classic dermatologic clues that would suggest HSV. Seizures occur commonly because HSV shows particular affinity for temporal lobe structures. These seizures may be the presenting sign before other symptoms develop, emphasizing why HSV should be considered in any neonate presenting with new-onset seizures, particularly in the 2nd to 3rd week of life. Diagnostic strategy centers on PCR testing because it provides the highest sensitivity and specificity for detecting HSV DNA in clinical specimens. PCR of vesicle fluid offers the most direct evidence when lesions are present. while blood PCR can detect viremic dissemination. CSF PCR becomes essential when CNS involvement is suspected, and serial CSF testing helps monitor treatment response because persistently positive CSF PCR indicates ongoing central nervous system infection. Viral culture remains valuable because it provides live virus for antiviral sensitivity testing, though results require 1 to 3 days compared to same-day PCR results. The time delay can impact treatment decisions in critically ill infants where immediate diagnosis guides therapy. Direct fluorescent antibody testing offers rapid results but lacks the sensitivity of PCR, making it useful for confirming diagnosis when lesions are present, but inadequate for ruling out infection when negative. CSF findings typically show pleocytosis with elevated white blood cells and increased protein levels. But early in the disease course, CSF may appear completely normal despite active CNS infection. This early normal phase explains why lumbar puncture timing matters, and why repeat testing may be necessary if clinical suspicion remains high. MRI reveals characteristic temporal lobe changes including edema, hemorrhage, or necrosis that reflect HSV's particular tropism for these brain regions. EEG demonstrates temporal lobe epileptiform activity, providing functional evidence of the anatomic damage seen on imaging. Treatment requires high-dose intravenous acyclovir at 60 mg per kilogram per day, divided every 8 hours, significantly higher than doses used for other viral infections. This intensive dosing reflects the need to achieve adequate central nervous system penetration and the severity of neonatal HSV infection. Treatment duration depends on disease classification and response to therapy. SEM disease requires 14 days of intravenous acyclovir, while CNS disease and disseminated disease both require 21 days because of the higher risk of treatment failure and relapse. The longer duration for CNS and disseminated disease reflects the difficulty in achieving viral clearance from these sites and the devastating consequences of inadequate treatment. Repeating CSF PCR before stopping treatment provides objective evidence of viral clearance from the central nervous system. Stopping treatment while CSF remains PCR positive risks relapse and progressive neurologic damage, making this monitoring step critical for ensuring adequate treatment. Suppressive therapy with oral acyclovir for 6 months following initial treatment represents a major advance in neonatal HSV management. This prolonged oral therapy reduces the frequency of cutaneous recurrences that can cause additional neurologic damage. More importantly, suppressive therapy has been shown to improve neurodevelopmental outcomes, suggesting that preventing even minor recurrences protects against ongoing brain injury. Monitoring renal function throughout treatment is essential because high-dose acyclovir can cause crystalluria and acute kidney injury, particularly in dehydrated infants or those with concurrent nephrotoxic medications. Cesarean delivery is indicated when active genital lesions are present at labor onset or when prodromal symptoms suggest impending outbreak. Primary HSV infection within 6 weeks of delivery requires cesarean section due to high viral shedding and maternal antibody absence. Cesarean section provides maximal protection when performed within 4 to 6 hours of membrane rupture. Vaginal delivery remains acceptable when no active lesions are present, and the most recent recurrent episode occurred more than 1 week prior to delivery. Women on suppressive antiviral therapy can deliver vaginally if asymptomatic. Once membranes have been ruptured for more than 4 to 6 hours, cesarean section offers no additional protection against transmission. Suppressive acyclovir therapy, beginning at 36 weeks, reduces outbreak frequency and viral shedding at delivery. Active outbreaks during labor require high-dose intravenous acyclovir. Suppressive therapy should continue postpartum in breastfeeding mothers. Primary infection carries a 10-fold higher transmission risk compared to recurrent episodes due to higher viral loads and absence of protective maternal antibodies. Asymptomatic viral shedding can occur, but transmission risk remains significantly lower than with active lesions. Prolonged membrane rupture increases transmission risk by allowing ascending infection and direct fetal contact with infected maternal secretions. Varicella-zoster virus creates 3 distinct clinical scenarios based entirely on when maternal infection occurs relative to delivery, each carrying dramatically different risks and outcomes. Understanding these timing patterns helps predict which infants face the greatest danger and guides immediate management decisions. Congenital varicella syndrome occurs when maternal infection happens before 20 weeks gestation, during the critical period of organogenesis. Despite this early timing, the transmission rate remains surprisingly low at only 2%, suggesting that most fetuses either resist infection or that infection results in fetal death rather than malformation. However, when transmission does occur during this vulnerable developmental window, it causes severe malformations that reflect viral disruption of actively forming organ systems. Perinatal varicella represents the most dangerous scenario, occurring when maternal infection develops between 5 days before delivery and 2 days after delivery. This narrow window creates a perfect storm, where mothers lack time to develop protective antibodies before delivery, yet infants receive maximal viral exposure during birth. The attack rate jumps dramatically to 30 to 50%, and without treatment, mortality reaches a devastating 30% because newborns lack both passive maternal protection and their own immune competence. Postnatal varicella, occurring after the first 2 days of life, typically results from exposure to infected family members or caregivers. While still serious, this timing allows for some maternal antibody protection if the mother has immunity and the infant's immune system has begun to mature slightly. The clinical manifestations of varicella-zoster virus infection reveal how viral tropism and developmental timing create distinct patterns of organ damage depending on when infection occurs during fetal development. Congenital varicella syndrome produces a characteristic constellation of malformations that reflect the virus's ability to disrupt multiple developing systems simultaneously. The cicatricial skin lesions appear as distinctive zigzag scars that follow dermatomal patterns, marking the sites where viral replication occurred during fetal skin development. These scars provide pathognomonic evidence of intrauterine infection because they represent healed lesions from active viral replication months before birth. Limb hypoplasia ranges from shortened digits to complete absence of limbs, demonstrating how viral infection during critical periods of limb bud development can arrest normal growth patterns. The ocular abnormalities, including microphthalmia and cataracts, occur because viral infection disrupts the precise developmental sequence required for normal eye formation during the first trimester. Cortical atrophy reflects direct viral damage to developing brain tissue, while neurogenic bladder indicates that the virus affects both central nervous system control and peripheral nerve development that governs bladder function. Neonatal varicella presents with the classic vesicular rash that appears in crops, starting on the trunk and spreading to extremities. However, the serious complications distinguish neonatal disease from typical childhood varicella. Pneumonia develops frequently and can cause respiratory failure, while hepatitis can progress to fulminant liver failure. Encephalitis represents direct viral invasion of brain tissue, causing seizures, altered mental status, and potential permanent neurologic damage. Management of varicella-zoster virus exposure and infection centers on understanding the critical timing windows that determine intervention effectiveness and disease severity. Prevention through varicella-zoster immunoglobulin, VZIG, becomes essential when maternal infection occurs in the dangerous window of 5 days before to 2 days after delivery. VZIG provides passive antibodies that can prevent or attenuate infection, but timing is absolutely critical. Administration must occur within 96 hours of birth to be effective. This narrow window reflects the time needed for passive antibodies to achieve protective levels before viral replication becomes established. Treatment of active neonatal varicella requires high-dose intravenous acyclovir at 30 to 45 milligrams per kilogram per day, significantly higher than doses used for older children or adults. This intensive dosing reflects both the severity of neonatal infection and the need to achieve adequate tissue penetration in rapidly growing infants. Standard treatment duration extends 7 to 10 days, though severe cases may require longer therapy based on clinical response and viral clearance. Isolation precautions must address varicella's dual transmission modes through both airborne droplets and direct contact with lesions. This dual transmission pattern requires both airborne isolation with negative pressure rooms and contact precautions to prevent spread through contaminated surfaces or direct touch. Exposed infants who received VZIG require isolation from day 8 to 21 of life because this represents the potential incubation period during which they might develop infectious varicella despite prophylaxis. This prolonged isolation period protects other vulnerable infants and healthcare workers from potential exposure. Varicella vaccination presents unique safety considerations because it contains live attenuated virus, creating specific risks and timing requirements for women of reproductive age that differ from inactivated vaccines. The live attenuated nature of the vaccine creates an absolute contraindication during pregnancy because even weakened virus theoretically poses teratogenic risks to developing fetuses. This contraindication requires waiting 1 full month between vaccination and any conception attempts, allowing sufficient time for viral clearance and ensuring no residual vaccine virus remains when pregnancy begins. When vaccination occurs inadvertently during pregnancy, current evidence provides reassurance because no cases of congenital varicella syndrome have been documented from vaccine virus exposure. However, this requires careful monitoring for maternal varicella development and documentation in pregnancy registries to continue tracking long-term safety data. Postpartum vaccination becomes both safe and strongly recommended for non-immune mothers because it protects against future pregnancies while posing no risk to nursing infants. The vaccine virus does not transmit through breast milk, making breastfeeding safe to continue during and after vaccination. Pre-vaccination requirements include pregnancy testing for all women of reproductive age to ensure no inadvertent exposure during early pregnancy when organogenesis is most vulnerable. Checking immunity status first prevents unnecessary vaccination in women who already possess natural immunity from previous infection. The critical nature of proper timing counseling cannot be overstated because reproductive age women must understand both the risks of natural varicella during pregnancy and the importance of achieving immunity before conception through proper vaccination timing.